Hello everyone and welcome back to Dental Steps at Daily. Today we are kicking off our ultra high yield video series designed specifically for Neet MDS aspirants. Preparing for a competitive national level exam is not about mindlessly memorizing thousands of MCQs. It's about building a solid conceptual foundation. That's why our series focuses on three main pillars. Focus on the conceptual why. We move away from rote learning and master the exact physiological mechanisms, pathology traits, and anatomical landmarks so they stick with you on exam day. Second, high yield clinical and image patterns. We tackle clinical photographs, CBCTs, IOPAs, and histopathological slides to match the evolving, highly clinical Neet MDS exam pattern. Third, the MCQ eliminator strategy. We break down the tricky options and clinical distractors so you can elevate your speed, precision, and ultimately secure your dream clinical seat in a top tier national college. Let's dive straight in, build your active recall, and conquer these high yield topics together. Before we tackle the first question, let's ground ourselves with today's quote of the day from the brilliant Viola Davis. All dreams are within reach. All you have to do is keep moving towards them. Aspirants, there will be days when your preparation feels overwhelming and your goals seem distant. Remember, consistency beats intensity. Every single MCQ you practice, every concept you master, and every slide you review is a step forward. Keep moving, keep showing up daily, and trust the process. You are closer than you think. Alright, let's jump into our first high yield question. According to Tsuchihashi classification, branched pattern of lip prints come under which type of lip print pattern? Our options are type 1, type 2, type 3 or type 4. Let's break down the classification on screen. Forensic chiloscopy or lip print analysis uses the Suzuki and Tsuchihashi system to categorize patterns into 5 key types. Type 1 consists of clear-cut vertical grooves running across the entire lip thickness, while type 1' represents partial vertical grooves. Type 2, which is our correct answer, specifically represents a branched or Y-shaped pattern. Type 3 is an intersected or crisscross pattern. Type 4 represents a reticular, net-like meshwork. Type 5 is for undetermined or irregular patterns that don't fit the others. Here is a clinical exam note. You must pay close attention here. Branched patterns are strictly categorized under type 2. Examiners love this topic because students often confuse type 2 branched with type 3 intersected. Remember, branched splits like a tree branch are Y-shaped, while intersected crosses over. Therefore, the correct option is B, type 2. Moving on to question 2. In question 2, you will be shown a histological image and asked, identify the type of cartilage shown in the diagram. To make sure you never miss a cartilage histology question again, let's look at our histological triad of cartilage. The hyaline cartilage has a smooth, glassy, homogeneous basophilic matrix containing type 2 collagen. The chondrocytes are housed in lacunae and are classic for being clustered together in isogenous cell nests, often looking like little pairs or group of eyes. You'll find this lining articular joints, tracheal rings, ribs, and nasal passages. Second is your fibrocartilage. This is highly fibrous, dense, and tough. Under the microscope, you will see dense, parallel, wavy rows of heavily eosinophilic type 1 collagen fibers. Notice how the chondrocytes are aligned in neat, alternating linear rows or strings. Crucially, fibrocartilage lacks a perichondrium. You will find this in the TMJ articular surfaces, intervertebral discs, and the knee meniscus. Third is your elastic cartilage. This features a densely packed, dark, intersecting network of elastic fibers in the matrix. Note that to clearly visualize this network, special stains like Verhoef's or Oracene are required. Chondrocytes here are tightly packed and larger. It's located in the pinna of the ear, external auditory meatus, and the epiglottis. Study the specific image provided in your exam. If you see clean, nested chondrocytes with a glassy background, it's hyaline. If you see dense collagen bundles with cells lined up in strings, it's fibrocartilage. If you see a dense network of fibers surrounding the cells, it's elastic. Master this triad and you have got this entire topic logged in. Question 3 brings us to clinical dental pathology. It says, upon examination of a patient's teeth, there is a greenish color discoloration seen on all the cervical thirds of the teeth. What is the most common cause of this condition? Our options are A. Amelogenesis imperfecta, B. Dentinogenesis imperfecta, C. Chromogenic bacteria, or D. tetracycline staining. The correct option is C. Chromogenic bacteria. Why? Let's analyze. Extrinsic green stains located precisely along the cervical third of the crown are classic indicators of chromogenic bacteria and fungi, such as Penicillium, Aspergillus species, or Actinomyces. These microorganisms produce color-forming byproducts that adhere to the dental plaque or cuticle in areas that are harder to clean, most commonly in children with poor oral hygiene. Now, why are the other options incorrect? Amelogenesis imperfecta is a genetic disorder affecting enamel, presenting as yellow-brown, rough, pitted surfaces across the entire tooth, not localized green cervical bands. Dentinogenesis imperfecta gives an opalescent, translucent, amber gray blue appearance to the teeth due to defective dentine. Tetracycline staining causes intrinsic banding, yellow, brown, or gray, deep inside the tooth structure, formed during tooth development not a green surface stain. Keep this distinction clear. Extrinsic plus cervical plus green is chromogenic bacteria. Let's look at question 4, which is a favorite of general pathology examiners. Which of the following are anti-apoptotic genes? The options are A. BAX, B. P53, C. BAC, and D. BCL2. To answer this instantly, let's look at the apoptotic balance on screen. Apoptosis or programmed cell death is controlled by a delicate scale. On one side, we have pro-survival anti-apoptotic genes led by the BCL2. Its action is to block the release of cytochrome C from the mitochondria, keeping the cell alive. On the other side, we have pro-death, pro-apoptotic genes, especially BAX and BAC. Their action is to form pores in the outer mitochondrial membrane, releasing cytochrome C and triggering the caspase cascade. P53 acts as the ultimate tumor suppressor switch. If DNA damage is too severe to repair, P53 upregulates BAX, tipping the scale decisively toward cell death. To make sure you never mix these up under the exam pressure, memorize these two diagnostic mnemonics. BCL2 can be remembered as be careful, live. These are anti-apoptotic, pro-survival. Whereas BAX and BAC bring, attack, X or kill. Pro-apoptotic promotes death. Using our mnemonics, we can easily eliminate the others. The correct option is D, BCL2. Question 5 is a classic interdisciplinary pharmacology and general medicine question. Propranolol is widely used in a thyroid storm to decrease the sympathetic activity of the thyroid gland, and the options are A. increases thyroid binding, B. increases iodization of thyroid, C. decreases conversion of iodine to tyrosine, D. increases release of thyroid from gland. Now, in a life-threatening thyroid storm, propranolol is a drug of choice because of its unique dual efficacy. Its anti-adrenergic action. It binds to beta 1 and beta 2 receptors, blocking adrenaline and noradrenaline. This immediately reverses the dangerous sympathetic symptoms like severe tachycardia, palpitations, and tremors. Second is enzymatic blockade. Beyond blocking receptors, propranolol inhibits the 5-D iodinase enzyme. This halts the peripheral conversion of relatively inactive T4 thyroxine into the highly potent biologically active T3 triiodothyronine. This is a massive high yield point. Let's quickly review the thyroid hormone hierarchy for your exams. The number in that name tells you how many iodine items are attached. T4 has 4 iodine. It's the main form secreted but acts as a less active prohormone. T3 has 3 iodines, the highly active potent driver of metabolic rate. T2 has 2 iodines, It influences mitochondrial activity. T1 has 1-iodine, an inactive precursor of or degradation product. By inhibiting 5-deiodinase, propranolol stops T4 from losing an iodine to become T3, rapidly lowering the active hormone levels. Thus, the correct choice is that it halts the peripheral conversion of T4 to T3. Let's move to oral pathology with question number 6. Dentigerous cyst arises from, our options are irritated pedial fibers, teeth with root caries, osteoradionecrosis, or unerupted tooth. Let's study the pathogenesis of a dentigerous or follicular cyst. Origin: it originates specifically from the reduced enamel epithelium surrounding the crown of an unerupted or impacted tooth. As shown in the diagram, fluid accumulates between the follicular tissue and the crown of the tooth. Diagnostic hallmark: radiographically you will see a well-defined unilocular radiolucency that attaches precisely at the cemento-enamel junction. It is most commonly associated with impacted mandibular, third molars and maxillary canines. Why are the other options incorrect? Irritated pedial fibers or cell rests of malassez give rise to inflammatory cysts like the radicular periapical cyst at the apex of non-vital teeth, not developmental cysts. Root caries lead to pulp necrosis and periapical inflammation, also leading to radicular cysts. Osteoradionecrosis is severe bone necrosis following radiation, completely unrelated to cyst development. Therefore, the correct option is D, unerupted tooth. Now question 7 deals with developmental anomalies of the definition. Identify the structures seen in the given radiograph. Our options include A. paradens, B. distal molar, C. paramolar, or D. supernumerary teeth. If your exam radiograph shows an extra impacted malformed tooth right at the midline between the maxillary central incisors, it is a mesiodens. Since mesiodens is a type of supernumerary tooth, supernumerary teeth is our correct umbrella option. Let's master the morphology of supernumerary teeth. First, supplemental. Eomorphic looks like a normal duplication. Example, an extra maxillary lateral incisor. Second, conical dysmorphic, small peg shaped. This is your classic mesiodens. Third, tuberculate dysmorphic. They are barrel shaped with multiple cusps. It typically delays the eruption of adjacent central incisors. Let's review the syndrome synthesis table because these are highly tested. Cleidocranial dysplasia, look for multiple impacted supernumerary teeth, delayed cranial suture closure, and hypoplastic or absent clavicles. In Gardner syndrome, it's characterized by supernumerary teeth, multiple jaw osteomas, and adenomatous colorectal polyps, which carry 100% risk of malignancy if left untreated. Cleft lip and cleft palate often presents with supplemental teeth adjacent to the cleft side. Know these associations inside out and you'll easily pick up these high yield points. Now let's look at question 8. A patient reported to the clinic with the chief complaint of pain in back tooth and gives history of trauma 5 years ago. Clinically, no significant changes are seen. Radiographic image depicts. So the options are external resorption, internal resorption, dens intente, dens imaginatus. Now, if you see internal resorption, the radiographic appearance shows a smooth, well circumscribed, symmetrical over ballooning radiolucency. The defining sign: the original outline of the root canal wall cannot be traced through the radiolucency because the canal walls themselves have ballooned outward. So you use slob rule. The radiolucency stays centered within the canal regardless of the X-ray tube angulation. External resorption: the radiographic appearance, you'll see an irregular moth-eaten radiolucency overlaying the root surface. The defining sign is the original unaltered outline of the internal root canal can still be traced completely intact directly through the radiolucency. Slob rule: the radiolucency will shift away from the canal when the X-ray tube angulation is altered. Keep these visual keys in mind during your exam to make a fast, accurate diagnosis. Moving to dental anatomy for question 9. Mesial marginal groove is present in which of the following teeth? Mandibular first premolar, maxillary first premolar, mandibular molar, or maxillary molar? The correct option is maxillary first premolar. Let's look at the key anatomical features of the maxillary first premolar. Mesial marginal developmental groove. This tooth is highly unique because its central developmental groove crosses straight over the mesial marginal ridge and spills onto the mesial surface of the crown. Mesial developmental depression. Just below this groove, this groove on the mesial surface of both the crown and root, there is a prominent concavity. This is a crucial anatomical landmark to remember for periodontal scaling and root canal preparation. Why are the other options incorrect? The mandibular first premolar does not have a mesial marginal groove. Molars have various developmental grooves, but a prominent groove crossing the mesial marginal ridge is not a defining characteristic for them. So remember, mesial marginal groove is equal to maxillary first premolar. Our final question, question 10, is the perfect companion to our previous topic. A mesiolingual developmental groove is seen in maxillary first premolar, maxillary second premolar, mandibular molar, or mandibular first premolar. Let's look at our anatomical mirror comparison. Examiners love testing these two grooves because students constantly get them mixed up. Maxillary first premolar features the mesial marginal groove. It's a distinct developmental groove that crosses straight over the mesial marginal ridge. Mandibular first premolar features the mesiolingual developmental groove. It originates from the mesial pit and angles down to separate mesial marginal ridge from the small non-functional lingual cusp. Think of them as anatomical mirrors. One crosses the mesial ridge on the maxilla, the other angles down mesiolingually on the mandible. Memorize this slide and you have mastered two of the most frequently tested landmarks in dental anatomy. I hope these explanations, mnemonics and diagnostic comparisons have made these tough topics simple and easy to remember. If you found this video valuable, please hit that like button, share it with your fellow aspirants, and subscribe to Dental Steps at Daily so you never miss our daily dose of active recall. Keep studying smart, keep moving toward your dreams, and I'll see you in our next video. Thank you and happy preparing.